Ischemia. What is ischemia? That is actually the lack of blood supply, lack of normal blood supply. Is actually there is accumulation of large amount of lactic acid in the tissues, which is formed as consequence of anaerobic metabolism, the metabolism without oxygen. So it is also probable that other chemical agents like bradykinin, proteolytic enzymes, they are formed in tissues because of cell damage, and that these in addition to lactic acid stimulate the pain nerve endings. Now, there is another cause of pain, and what is that? That is the muscle spasm. And it is quite common cause and is the basis of many clinical pain syndromes. This probable, pain probably results partially from direct effect of muscle spasm in stimulating mechanosensitive pain receptors, but it might also result from indirect effect of muscle spasm to compress the blood vessels and cause ischemia. So we can say that the mechanical factors are there, as well as there is compression of blood vessels leading to ischemia, which is one of the causes, and the spasm increases the rate of metabolism in the muscle tissue. At the same time, there is ischemia, which is again accelerating the accumulation of more and more lactic acid, so more and more production of chemical pain-inducing substances, they are there. Now we should be knowing about the dual pathways for transmission of pain signals into the central nervous system. All the pain receptors, they are free nerve endings. These endings use two separate pathways for transmitting the pain signals into CNS. The two pathways correspond to the two types of pain: a fast, sharp pain pathway and a slow chronic pain pathway. Now we have the peripheral pain fibers, which are fast and slow. The fast sharp pain signals are elicited by, as we already have done this, that by the fast sharp pain signals, they are being elicited by mechanical or thermal stimuli, and they are being transmitted by peripheral nerves to the spinal cord by A delta fibers. Velocity is 6 to 30 meter per second, and the slow mostly by the chemical type of stimuli, and sometimes by mechanical or thermal, and they are being transmitted by C type of fibers, and the velocity is quite low in comparison to the fast ones, that is around 0.5 and 2 meter per second. You can see the fast sharp pain fibers, how they enter the spinal cord, and then they're going to decussate to the opposite side, and then they're going to ascend in the anterolateral pathway, and they are going to decussate at the level of spinal cord, they are going to ascend, and then the second order neuron arises from over here, and then they are going to relay over there in the thalamus. From the thalamus, the third order neuron arises and it goes to the somatic sensory area 1. Now look at this. We have the slow pain fibers, we have the sharp pain fibers. You can see that the pain tracks on the way to the thalamus, they are having the continuous intermingling with that of the reticular formation. So they are at the same time going to the CNS via reticular formation interaction, as well as in the form of the anterolateral pathway. Because of this double system of pain innervation, a sudden painful stimulus often gives a double pain sensation. So a fast, sharp pain that is transmitted by A delta fiber pathway, followed a second or later by slow pain that is being transmitted by C fiber pathway. So they are actually enhancing one another. The sharp pain apprises the person rapidly of a damaging influence and therefore plays an important role in making the person to react immediately. So immediately the person is going to call for a doctor or so, or tries to actually remove himself or herself from that stimulus, if that's something from outside, or if that is the slow pain which tends to become greater over time. The sensation is actually a sort of discomfort and eventually intolerable pain, making the person trying to relieve the cause of the pain, because that is actually damaging the person from inside or from outside. So on entering the spinal cord from the dorsal spinal roots, the pain fibers they terminate or relay neurons in the dorsal horns. So here again, there are two systems for processing the pain signals on their way to brain. So the first order neuron is actually the free nerve ending, and that is going to relay over there in the dorsal spinal root. In the dorsal horn of the spinal cord. Now let's talk about the dual pathway. Now what is this dual pathway? We have a neospinothalamic tract and a paleospinothalamic tract. The pain signal is going to take either of these two tracts to go to the brain. First one is the neospinothalamic and the other one is the paleospinothalamic. Now this neospinothalamic A delta fibers, that is for the fast pain. Now the first type, A delta pain, they're going to transmit the information if there is pain due to some mechanical or thermal type of damage. They are going to terminate mainly over there in the lamina 1 of the dorsal horn, and then they are going to excite the second order neuron and going to decussate and going to give rise to long fibers going to opposite side of the cord through anterior commissure, and then they are going to turn upwards, passing to brain in the anterolateral columns. Now look at this diagram. This is actually telling us about the neospinothalamic tract for fast pain. You can see how the free nerve endings, they're going to enter the dorsal column of the spinal cord, and then they're going to relay in the lamina 1, 2, and they're going to go to the opposite side. They're going to cross over, and the second order neuron arises from over here and is going to go up in the form of anterolateral tract and is going to go to the thalamus, going to relay there again, and from over there the fibers they go and to the sensory cortex. All of you are supposed to make these pathways of pain sensation as well. Then we have the paleospinothalamic tract. Now what is this? A few fibers of the neospinothalamic tract terminate in the reticular areas of the brainstem, but most pass all the way to the thalamus, especially through the ventrobasal complex of the thalamus, along with the dorsal column medial lemniscal tract for tactile sensations. A few fibers that terminate in the posterior nucleus area of the thalamus, and from these thalamic areas the signals they are being transmitted to the other basal areas of the brain as well as to the somatosensory cortex. Now you can see this paleospinothalamic tract, you can see that as this anterolateral pathway that is going up, they are going to have the connections with that of the reticular formation at the same time, and they have they are going to give rise to the fibers again to the thalamus, then to the primary sensory cortex, and in this way we have the two type of pathways for pain sensation. One neospinothalamic for the fast pain sensations, and for the slow pain sensations we have paleo-spinothalamic tract. And over here, what is the important thing which is actually helping us is the reticular formation. Now there is capability of the nervous system to localize the fast pain in the body. The fast, sharp type of pain can be localized much more exactly in different parts of the body than can the slow chronic pain, as you can experience it yourself, that if somebody hits you, you can easily tell bluntly that he or she has hit me on this area. But if you have a vague sort of abdominal pain, you cannot sometimes tell a person what is the exact spot. So when only pain receptors they are stimulated without the simultaneous stimulation of tactile receptors, even fast pain can be poorly localized. Often only within 10 centimeter or so of the stimulated area. When tactile receptors that excite the dorsal column medial lemniscal system are simultaneously stimulated, the localization can be nearly exact. So we can say that during the course of this fast, sharp type of pain, these tactile receptors, this dorsal column medial lemniscal system is actually quite helpful for the person to localize the exact area which is being affected. Now let's talk about glutamate, the probable neurotransmitter of the type of the fast pain fibers. Glutamate is the neurotransmitter which is actually being secreted by the spinal cord at A delta pain nerve fibers. It is one of the excitatory transmitters in the CNS. Duration of action only lasts for a few milliseconds. Then let's talk about the paleo-spinothalamic pathway for slow chronic pain. This is much older system and it transmits pain mainly from the peripheral slow chronic C type of pain fibers. And although it does not transmit the signals from A delta fibers, it is actually transmitting signals from only C type of pain fibers. And in this pathway, the peripheral fibers that terminate in spinal cord in lamina 2 and 3, which together are called substantia gelatinosa. See, they are going to relay over there at the lamina 2 and 3, known as substantia gelatinosa. Most of the signals then pass through one or more additional short fiber neuron and within the dorsal horn before they are going to enter mainly lamina 5. And the last neuron in the series giving rise to long axons that mostly join the fibers from the fast pain pathway, passing first through anterior commissure to opposite side, then upward to brain in anterolateral pathway. Substance P. The research suggests that type C pain fiber terminals entering the spinal cord, they release both glutamate as well as substance P transmitter. The glutamate transmitter acts instantaneously, rapidly, and is lasting only for a few milliseconds, whereas substance P is actually released very slowly, and its concentration builds over periods of seconds or even minutes. In fact, it has been suggested that double pain sensation one feels after a pinprick might result partly from the fact that glutamate substance gives a faster sensation and then later on substance P is going to give us the lagging sensation. Glutamate is the neurotransmitter which is involved in fast pain transmission in CNS. Substance P is concerned with slow chronic pain. Projection of paleo-spinothalamic pathway. The slow chronic paleo-spinothalamic pathway terminates widely in the brainstem. Only 1/10 to 1/4 of fibers pass all the way to the thalamus. Instead, Most terminate in one of the areas like medulla, pons, mesencephalon.